I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. A bad bellyache gets your attention fast. One possible cause is diverticulitis, which can be a medical emergency. This is the People's Pharmacy with Terry and Joe Graydon.
How can you tell the difference between diverticulosis, diverticulitis, and appendicitis? Is there anything you can do to keep diverticulosis from flaring up into diverticulitis? How do you stay out of the emergency room?
What's the best diet? Sometimes people get conflicting recommendations, which can be confusing. Our guest, gastroenterologist Robin Chutkan, clarifies what to eat and what to avoid.
Coming up on the People's Pharmacy, get the details on diverticula.
First, the news.
In the People's Pharmacy health headlines, there's growing evidence of a link between dementia and drugs that interfere with the neurotransmitter acetylcholine. Such anticholinergic drugs include antidepressants like amitriptyline or paroxetine, medications for Parkinson's disease, such as benztropine, medicines for overactive bladder like tolterodine, and anticonvulsants such as carbamazepine. British researchers reviewed the medical records of more than 250,000 people in primary care practices in the UK. There were nearly 59,000 individuals who had been diagnosed with dementia. Each one was matched to 5 controls of similar age who had no dementia diagnosis. In looking back over more than a decade of prescriptions, the investigators found that people who had taken anticholinergic medicines were almost 50% more likely to get a dementia diagnosis. Those with greater total exposure had a higher risk. In an accompanying editorial, scientists call for de-prescribing trials that would test whether taking people off anticholinergic drugs would lower their likelihood of developing dementia. People should not stop taking such medicines on their own, since stopping an anticonvulsant or an antipsychotic drug could be dangerous.
How can you protect cognitive function as you age? Studies have shown that in Mediterranean countries like Spain and Greece, people who follow a more traditional Mediterranean-style diet appear less likely to develop dementia. Now, a study in the UK finds that the same is true even in countries where a Mediterranean dietary pattern is not traditional. An analysis of data from the European Prospective Investigation into Cancer and Nutrition in Norfolk, England, demonstrates that people who consume more fruits and vegetables and fewer meats and sweets score better on cognitive tests. The researchers analyzed data on over 8,000 older individuals. Those at higher risk for cardiovascular disease were less likely to perform poorly on cognitive tests if they followed a traditional Mediterranean dietary program.
For years, cardiologists have warned their patients to be cautious about consuming too many dairy products. They worried that dairy fat would clog arteries. A randomized clinical trial from the Netherlands suggests, however, that a high dairy diet can actually help overweight middle-aged adults lower their blood pressure. In this crossover study, 52 volunteers consumed a low dairy diet with less than 1 serving a day, or a high dairy diet with 5 to 6 servings of low-fat dairy products daily. The investigators defined 1 portion of dairy as a cup of low-fat milk or buttermilk, or 3/4 of a cup low-fat yogurt, or a 1-ounce slice of low-fat cheese. Each diet trial period lasted 6 weeks, and there was a 4-week washout period between them. Blood pressure was measured at the beginning and end of each experimental diet period. During consumption of a high dairy diet, blood pressure dropped by about 5 points systolic and 3 points diastolic. This was a significant difference. The DASH diet, which has been shown to reduce blood pressure, is rich in low-fat dairy products. Perhaps some of the DASH diet benefit is due to its dairy product content.
For decades, Americans embraced antibacterial products. They sought out hand sanitizers, soaps, kitchen cleansers, toothpaste, and cosmetics with an ingredient called triclosan. It's also been found in toys, clothing, and kitchen products. Then, researchers began warning that triclosan could be an endocrine disruptor. In other words, it might affect hormone function in the body. Last April, the FDA banned the chemical's use in hand sanitizers, but triclosan can still be found in some toothpastes, antibacterial soaps, and deodorants. Now, scientists publishing in the Journal of Clinical Endocrinology and Metabolism report an association between triclosan exposure and osteoporosis. They tracked triclosan in the urine of more than 1,800 women between 2005 and 2010. Those with the highest levels of urinary triclosan had the lowest bone mineral density. In postmenopausal women, high triclosan levels were associated with the risk of osteoporosis. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. Have you ever had a really bad bellyache that didn't go away? What did you do? Many people take antacids or proton pump inhibitors whenever they have abdominal discomfort. That might work for heartburn, but not for something called diverticulitis. What is it, and how is it different from the related condition called diverticulosis?
To help us understand diverticulitis and diverticulosis, we're talking today with Dr. Robin Chutkan. She's on the faculty at Georgetown University Hospital and is founder of the Digestive Center for Wellness in Washington, D.C. Dr. Chutkan is a board-certified gastroenterologist and the author of 3 books on digestive health. The first was Gut Bliss, which is the name of her website. She's also written The Microbiome Solution and The Bloat Cure.
Welcome back to the People's Pharmacy, Dr. Robin Chutkan.
Thank you so much, Terry and Joe, for having me back. It's always such a pleasure to be with you on the People's Radio.
And it's great to have you with us again. Dr. Chutkan, we hear from people who occasionally have an attack of diverticula something, losis, litis. All we know is that for them, it is incredibly painful. Sometimes they end up in the hospital. It's so bad. Can you explain what the difference is between diverticulitis and diverticulosis? But more important, what the heck are diverticula anyway?
Joe, I'm so glad you asked this because this seems to be one of the most confusing aspects of digestive disease for people, the difference between itis and osis. So diverticulosis refers to the presence of what I like to call potholes in the colon, these little pockets that develop usually in the bottom half of the colon, the sigmoid colon. And diverticulosis is incredibly prevalent in the US, more than 50% of the population over 50. And part of the reason why is that, unfortunately, most people in America eat what we call the SAD diet, the standard American diet, which is a diet low in fiber. And a diet low in fiber is precisely what causes diverticulosis. So that's the osis. Osis refers just to the presence of these potholes in the colon. Now, to further confuse things, you can have diverticulosis and be completely asymptomatic, or you can have diverticulosis and have a lot of symptoms. And what are the symptoms of diverticulosis? So again, we're just talking about the presence of the potholes. The classic hallmark symptom is something called tenesmus, which is a fancy way of saying incomplete evacuation. And what that feels like if you're a patient with diverticulosis is you sit down on the toilet to go, and you feel like you have to go, and you push and strain, and just a couple stingy little bits of stool come out. And they're often little pebbles because they're actually casts. They're stool that have been sitting in these potholes, and so they come out in this round shape. or they can come out narrowed and stringy, almost like toothpaste. And that's because the colon itself can become more narrowed with the diverticulosis because of thickening of the wall. So the commonest symptom of diverticulosis is incomplete evacuation, a feeling like you have to go, but it's not all coming out, and often multiple stools. So it's almost like a form of constipation, but when you think of constipation, you think of people not going. But in this case, people are going multiple times a day, but each time a small amount of stool incomplete. So that's diverticulosis. Now, diverticulitis, and here's a little medical nugget for our listeners. Anything that's itis in medicine means inflammation. So arthritis is inflammation of the joint, dermatitis, inflammation of the skin, colitis, inflammation of the colon, and diverticulitis, inflammation of the diverticulosis. So in order to have diverticulitis, you need to first have diverticulosis. You need to have the presence of the diverticular orifices, or the little potholes. And then what happens is those potholes become inflamed. Now, remember, I just said you can have diverticulosis and have no symptoms at all. But let's say you start taking a lot of ibuprofen for knee pain. Ibuprofen is one of those things that in the gut can cause inflammation. Even though it can be helping inflammation in your knee, it sort of has the opposite effect in the gut. So ibuprofen can cause inflammation, and specifically can flare up the diverticulosis so that now you have diverticulitis. So now those pockets are inflamed. And when I do colonoscopy, Joe and Terry, I actually see pus in those little pockets, little pus-filled pocket. Now, we try not to do a colonoscopy when somebody has active diverticulitis because they're in a lot of pain. They can have fever. The colon's really inflamed. It's a higher risk doing a procedure with active inflammation. But every now and again, we have to, and we actually see the pus coming out of these pockets. So diverticulitis, the main symptom is pain. And people can sometimes have a fever. If you get your labs drawn, you can have an elevated white blood cell count, a marker of inflammation. And the diverticulitis can turn into an actual infection that can require hospitalization, intravenous antibiotics. People can be quite sick. People can lose their colons. People can even die from a really severe episode of diverticulitis, although that is by far the exception rather than the norm.
I had no idea that it could be so serious. I knew that it was terribly painful.
Yes, it definitely can be. And then, again, it's a broad spectrum. So you have one end of the curve, people with diverticulitis who are really sick and in the hospital on intravenous antibiotics. And then you have the other spectrum of people with diverticulitis who are, I'm having a little discomfort. Maybe I'll go light for dinner tonight, but are in pretty good shape. And I wanted to mention the food thing because for anybody who's suffering from an acute episode of diverticulitis, bowel rest, going on a liquid diet or not eating anything at all is one of the really important things for helping to cool down that inflammation. If you have a really inflamed colon with all these pockets and pus coming out, the last thing you want to be doing is eating a big meal.
Dr. Chutkan, there are so many things that can happen in our abdominal cavity, in our digestive tract, and it can be hard for people to actually know what's going on. In other words, is it an attack of appendicitis? Obviously, inflammation of the appendix. Is it just I ate the wrong kinds of foods and maybe now I'm having, some kind of bad heartburn and it's not going up, it's sort of going down? Or, just a general irritable bowel syndrome, whatever we mean when we say that. So how would somebody know if they're having an attack of diverticulitis?
Well, Joe, when I approach a patient, I'm always thinking a new patient, and whether that's in my office, in the hospital, in the emergency room, there are always two things going through my mind. What's the most likely diagnosis and what's the most lethal diagnosis? So what is the likely thing, the thing that is probably going on, but what's the thing I don't want to miss? What's the most lethal thing that this could be that if I missed it, this patient's really going to be in trouble? And so I really encourage people as they think about their own health, and particularly as they start to learn how to have a dialogue with their digestive tract, to think in terms of these sort of two things. What's the worst thing this could be? What's the thing that I really need to go to the emergency room for them to exclude because if I miss it, I might really be in trouble, versus what's the likelihood? And to help with that, there are some red flags that people should be aware of. one of the really important red flags is fever. If you have a fever, real fever above 101 degrees Fahrenheit, that's something that should sort of really get your attention and think. Now, you can have fever with more benign things like some sorts of food poisoning, etc. But if you have a fever, that puts you really in the category of things like appendicitis, diverticulitis, even a bowel perforation, which is where something has a hole in it, and that can be a surgical emergency. So fever is something that should really have you thinking, maybe I need to make an urgent call to my internist, or maybe I need to head to the nearest emergency room. The other thing is how severe the pain is. And pain, of course, is a very objective symptom, a rather very subjective symptom. It can vary. One person's 10 on a scale of 1 to 10 could be another person's 5 or even another person's 3. But within your personal experience for pain, if this pain feels different from other pain you've had, way more severe than other pain you've had, that again should really make you think, maybe I need to have this evaluated more quickly. If you are having vomiting along with the pain, that's something else to think about. So again, fever, severe pain, vomiting, and I would also add to that blood in your stool. These are things that in general terms in the GI tract make us worry about. And when I say blood in the stool, I don't mean a little blood on the toilet paper on a regular basis, but bleeding in the setting of some of these other signs and symptoms. So those are some of the questions as people are trying to figure out, is this just a little stomach upset because I ate too much, had one too many slices of pizza the night before, ate something that didn't agree with me, or should I be really worried? And also, what happens to the pain? Is it getting more severe rather than less? Is it sort of crescendoing where it's getting really severe and waves, or is it getting better? So again, these are really kind of subjective calls, but this is why it's so important to really get to know your body and get to know your digestive tract and have that dialogue so that when it gives you this feedback, you can really sort of interpret it and understand what it's trying to tell you.
You are listening to gastroenterologist Robin Chutkan. Dr. Chutkan is founder of the Digestive Center for Wellness in Washington, D.C., and she's on faculty at Georgetown University Hospital. She's written 3 books, Gut Bliss, The Microbiome Solution, and The Bloat Cure. Her website is gutbliss.com.
And Terry, what were those red flags that Dr. Chutkan was talking about?
Well, she mentioned fever. That's very important, a fever of more than 101 degrees Fahrenheit. So if you have fever, that's a red flag. If the pain is more severe than other pains you have experienced, that's a red flag. If you have vomiting or blood in the stool, anytime there's blood in the toilet, that's kind of a red flag. And if the pain is becoming more intense, then that's another red flag. So you really need to pay attention to all of those. It doesn't tell you what's happening, but it tells you something is very wrong.
See a health professional. After the break, find out what causes diverticular disease.
How can you prevent problems? People are sometimes told to watch their diet, but there's a lot of conflicting information on what to eat and what to avoid.
If you're following a high-fiber diet, how do you avoid nuts and seeds that could cause trouble?
What's the official diverticulitis diet?
Are there drugs that make diverticulosis worse? Which ones are they?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
The People's Pharmacy podcast is sponsored in part by Kaya Biotics. Kaya Biotics offers the first probiotics which are both certified organic and hypoallergenic.
All probiotics are produced in Germany under laboratory conditions with high-quality ingredients and under strict regulatory oversight.
The 3 available formulas are created for very specific purposes, such as strengthening the immune system, fighting yeast infections, and helping with weight loss.
To learn more about Kaya Biotics probiotics and the important topic of gut health, you can visit their website, KayaBiotics.com. That's Kaya Biotics.com. Use the discount code PEOPLE for $10 off your first purchase. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. If you would like to purchase a CD of this show, you can call 800-732-2334. Today's show is 1171. That phone number again, 800-732-2334, online at peoplespharmacy.com. You can also download the podcast from our website or wherever you get your podcasts.
The People's Pharmacy is brought to you in part by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verizana.com.
We're talking today about a surprisingly common digestive tract condition called diverticulosis and its cousin, diverticulitis.
Our guest is gastroenterologist Robin Chutkin. Dr. Chutkin is founder of the Digestive Center for Wellness in Washington, D.C., and on faculty at Georgetown University Hospital. She's written 3 books, Gut Bliss, The Microbiome Solution, and The Bloat Cure.
Dr. Chutkin, you were talking about, really severe pain. And I have to tell you about I can laugh now. It was a very unpleasant experience from last August. We were flying home from San Francisco to Raleigh-Durham, North Carolina. And even before I got on the plane, I was in pretty significant discomfort, abdominal pain. And it just kept getting worse and worse. And it got so bad that I actually thought about telling the flight attendant that it would be a really good idea if the pilot landed the plane. It was that bad. I mean, about an 8, maybe sometimes a 9 on a 1 to 10 scale. And then I thought, this whole plane of people are going to be so angry with me, I'm just going to tough it out. When we got home, we ended up in the emergency room, not surprisingly. They did a CT scan and they said, "Oh, you are a classic case of intussusception. It's really rare in adults." Can you tell our listeners what that is and why it's an emergency?
Absolutely. So it is an emergency and it is really rare. And intussusception, it's as hard to spell as it is to say, refers to when one part of the bowel sort of herniates into another part of the bowel. And the net effect is that it causes a bowel obstruction. And when you have a bowel obstruction, it means that the products of digestion can't get through, not just any food you might have eaten, but also the liquid that the bowel is secreting all the time, the air that's being produced, the gas that's being produced by the bacteria. So even if you're not eating anything, a bowel obstruction can still be a huge problem. So with the intussusception, the bowel twists into itself and causes an obstruction. And the bowel upstream to the obstructed area starts to dilate and dilate and dilate. And if you don't do anything about it, it can pop. So, I'm not surprised that you were considering asking the pilot to land the plane. I'm so glad it had a happy ending and you didn't have to make an emergency landing. And what did happen? Did it resolve on its own, or did you need surgery?
The surgeons arrived and they said, "This is not optional. You need surgery." I had a benign lipoma, which is what triggered the intussusception, and they removed everything, and everything is fine. I lost about 10 inches of my small intestine, but it resolved the problem. Thank goodness. But it brings to everyone's attention how very serious abdominal pain deserves treatment, maybe even emergency treatment. And fortunately, that took place, and I did recover. But that brings us back to this whole issue of diverticulosis and more significantly, diverticulitis.
And Dr. Chutkin, I am wondering if you can tell us what causes diverticular disease, and what do you do to treat diverticulitis, and how can we prevent it?
Terry, there are many things in the digestive world that are sort of multifactorial that have lots of causes, but diverticulosis is one of those where there's one main cause, and that's not enough fiber. A diet that is too low in fiber, and conversely, usually too high in animal protein and fat. So the typical Western diet, lots of meat, not a lot of vegetables. If we look at parts of the world where people eat a lot of fiber, so to give some numbers to this story, in the US, we recommend a minimum of 25 grams of fiber a day for women and 35 grams for men. But most Americans are eating somewhere south of 12 grams of fiber a day. And unfortunately, a lot of that fiber is in processed form. It's breakfast cereal and breads and so on. It's not root vegetables and leafy greens. But if we travel across the globe and we visit countries where people eat a lot of fiber, and often for economic reasons, they can't afford to eat meat, animal protein is expensive. So if we look at sub-Saharan Africa, for example, in more rural populations where people are eating 50 and 60 grams of fiber, they have virtually no diverticulosis. They also have virtually no colon cancer, no inflammatory bowel disease. So they have really highly functioning gastrointestinal tracts. Now, they have other things to worry about. They have cholera and malaria and lots of other things. So their problem are really more communicable diseases. Whereas in the West, based on our diet and lifestyle, we have to worry more about non-communicable diseases like diverticulosis and diabetes, etc. And in the case of diverticulosis, it's purely a function of the diet. And the reason a high fiber diet is so protective is fiber bulks the stool. It produces a nice, big, bulky stool that the colon is able to easily expel. When you're eating a Western diet, low in fiber, you have a hard, small stool. And the sigmoid colon, that end part of the colon just above the rectum, that part of the colon has to contract really vigorously to push out that small, hard Western stool. And over time, that continual vigorous contraction and pushing and straining leads to diverticulosis. And it also leads to hemorrhoids typically, which is why hemorrhoids and diverticulosis are often fellow travelers. So the number one thing you can do is to increase the fiber in your diet if you're concerned about diverticulosis. People often say to me, oh yes, my father had it, my mother had it, my aunt had it, must be genetic. Not genetic, but we know that families tend to live in similar ways. And if your parents ate a low fiber diet growing up, chances are you probably ate a low fiber diet growing up too. Plus, again, this is super common, more than 50% of the population over 50, but not genetic, related to lifestyle factors. Now, one quick caveat, for diverticulosis, a high fiber diet is really important for preventing progression, for preventing growing more of these potholes, or for preventing it from developing in the first place. But if you already have diverticulosis and you think you're having an attack of diverticulitis, you want to get rid of the fiber for that immediate period because you want to sort of rest the bowel. So you have diverticulosis, eat lots of fiber to prevent diverticulitis and to prevent more diverticulosis from developing. But in the setting of an acute attack of diverticulitis, you want to get rid of the fiber and allow the colon to rest and decompress.
Now, if you have diverticulosis and you don't have the belly pain and the fever or any of the other signs of inflammation, you don't have symptoms, but you know you have diverticula, so you want to go for that high fiber diet. Where do you find the fiber?
You find the fiber from the ground. So, nutrition can be very confusing. You have to have an MD and a PhD these days to sort of really understand. But I like to break it down for my patients because the truth is, it's not actually complicated. When you think about fiber, think about where the food came from. Was it picked from a tree or a bush or dug up from the ground versus did it come from the factory? So, for example, apple, great, came from an apple tree. Applesauce, typically from the factory. Potato from the ground. Potato chip from the factory. So if there's not a tree or bush or plant that bears it, not a great source of fiber. So fiber, lentils, a bag of lentils that, again, were harvested, very different from a lentil chip or even a loaf of bread. There's no bread tree or plant or shrub. So in trying to distinguish, because I tell you, the marketing is very clever. You see all these labels on the food, 15 grams of fiber, 9 grams of protein, looks great. But if you're eating food that doesn't have a label on it, even better. So the bag of sweet potato or peaches or kale or cauliflower that you're buying at the supermarket or from the farmer's market ideally doesn't even have any nutrition labeling on it. And that's really what you should be going for. So unprocessed fiber from fruits, vegetables, nuts, seeds, legumes, right from the ground, ideally.
Now, Dr. Chutkan, you just mentioned nuts and seeds. And I know that people who have had problems with diverticulitis, one attack, let's say, and they've been diagnosed, they are given the diverticulitis diet, which is basically forbidden fruits, nuts, seeds, stuff that, quote unquote, could get lodged in those pockets. How good is the data to support that diet? And what do you recommend for people who have gone through this and never want to repeat that experience again?
So some of these harder, sort of difficult to digest things like baby carrots and partially popped popcorn can be difficult. Nuts, because they can sometimes have sharp edges. So if you're going to have nuts, you should chew them really, really carefully. But I think these caveats are really for people who've had episodes of diverticulitis and been really sick, as opposed to somebody who just has diverticulosis, where their goal really is to massively ramp up the fiber.
Dr. Chuckin, are there medications for a bout of diverticulitis? Are there things that doctors prescribe, and are they helpful?
And are there drugs that people should avoid?
Well, the remedies for diverticulitis are really for the secondary symptoms, namely the inflammation and the infection. And that would primarily be antibiotics to help if there's active infection. Now, there are antispasmodics that people can sometimes use for symptoms, but there really isn't a drug to treat this whole syndrome of diverticulosis. That's really a dietary therapy. But again, in the setting of acute diverticulitis, an antibiotic, IV hydration if the patient's dehydrated because they've not been able to take in much by mouth, those things can be really helpful. And again, in terms of prevention, an apple a day, quite literally in this case.
That sounds like actually a delicious way to prevent a problem. Now, when we talk about antibiotics, what comes to mind is antibiotics are certainly necessary in some cases, but they can have very negative impact on the digestive tract because of their effect on the microbiota.
Absolutely. And I'm so glad you mentioned the microbiome or the microbiota. We're really referring to the same thing, one of my favorite topics. And the startling fact is that just 5 days of a broad spectrum antibiotic of the type you would take for, let's say, a sinus infection or a urinary tract infection, etc., can remove up to a third of your gut bacteria. And no amount of probiotics is ever going to bring those species back with the same diversity and fullness as when they were initially present. So antibiotics, the most important thing is judicious use. None of us should be taking an antibiotic unless absolutely necessary. In the case of, a severe case of diverticulitis, you're sick, you have pain, fever, your white blood cell count is elevated, you're in extremis, absolutely, an antibiotic is a great idea. But, you've got a little crampy pain. And by the way, the pain and discomfort from diverticulosis and or diverticulitis is usually on the left side, low down, because that's where the sigmoid colon is. Some people have diverticulosis throughout the colon, and they can have abdominal pain that's more diffuse or even localized to the right side. But the vast majority of the time it will be low down on the left side or in the mid area. And in women, they'll often confuse a pain and think they have a urinary tract infection because a sigmoid colon in women sits pretty low down in the pelvis, and it can be right in front of the pubic bone. And so if you start having pain down their midline, low down, frequently women will think they're having a urinary tract infection. Sometimes if the sigmoid colon is really inflamed with diverticulitis, it can actually sort of irritate the bladder. So there's frequent urination also. So I want to make the point that if you're a woman out there and you think you're having a urinary tract infection, it's always a good idea to get a urinalysis and a urine culture and never just to presumptively take an antibiotic, because it could be diverticulosis, not even itis. It could be just a very full colon that's full of stool and all the potholes that's irritating things and not a urinary tract infection.
So, Dr. Chuckin, you've mentioned that for diverticulitis, where people have a fever and they're in quite a bit of pain, that an antibiotic, a course of treatment would be appropriate. But I'd like to talk about some of the drugs that might actually make diverticulosis worse. And you mentioned the nonsteroidal anti-inflammatory drugs. People love these medications, ibuprofen,
Yes.
naproxen, but they can be inflammatory in the bowel. But what about other drugs? For example, some of the older-fashioned antidepressants that people now take a lot of the time for insomnia, for example, or antihistamines that have what we call anticholinergic activity and slow down the bowel activity. Are there problems there?
There are huge problems there, Joe, and I'm so glad you mentioned antidepressants because a study from earlier this year in 2019, a review study, looked at a class of drugs called selective serotonin reuptake inhibitors, or commonly known as SSRIs. And SSRIs are prescribed to somewhere between 10 and 15% of the population. They're incredibly common medications in use in the US. And this study did a complete review of the literature, and they found that people taking SSRIs are at a whopping 40% increased likelihood of experiencing gastrointestinal bleeding and other complications too. They're at a higher risk of life-threatening bleeding in the brain too. But for my purposes and our purposes today, we're more focused on the gut. So this was really very startling because, again, these drugs, more than 1 in 10 Americans, adult Americans, are taking these drugs. And many of the people taking these drugs, we talk about more than 50% of the population having diverticulosis. Now, we spent a lot of time talking about diverticulitis, but the other thing that can happen with diverticulosis, besides inflammation, which is diverticulitis, is bleeding. So even in the absence of diverticulitis, uninflamed diverticular orifices, those pockets, can bleed. And that happens because with a pothole, there's a little bit of thinning of the lining, and those small blood vessels are now closer to the surface. And so something that causes a little bit of surface erosion, like a nonsteroidal anti-inflammatory drug, or even food going through the GI tract, can cause bleeding. And so now we know that people taking these SSRIs are at this incredibly increased risk of bleeding. So it's really important to start connecting the dots. I like to tell my husband, the body is very logical. We see these things happening and we think they fall out of the sky. But so often, if you trace those breadcrumbs back, you can see where this started to happen. And so this is sort of a perfect storm here. Somebody who's taking an SSRI also has diverticulosis and maybe also taking some ibuprofen, some form of an NSAID for knee pain or something, and all of a sudden they're having massive gastrointestinal bleeding. So really, really important. Remember, every drug that you take goes through the digestive tract. Many of them are metabolized in the liver, filtered through the kidney, but they all can potentially affect the GI tract, and some of them can have a really profound effect on the GI tract, like the antibiotics we talked about and the effect on the microbiota and gut bacteria, like the SSRIs and the increased risk of gastrointestinal bleeding, and like the nonsteroidals with, again, the increased risk of inflammation and bleeding.
You're listening to Dr. Robin Chutkan. She's founder of the Digestive Center for Wellness in Washington, D.C., and on faculty at Georgetown University Hospital.
After the break, we'll talk about the consequences of a low-fiber diet.
Find out how to protect the lining of your digestive tract.
Get a crash course on heartburn and proton pump inhibitors.
You'll also learn about fecal transplants and super poopers.
What are the most important factors for good digestive health?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
This People's Pharmacy podcast is brought to you in part by Verisana.com.
Verisana Lab offers home health tests that allow you to monitor your hormones and health conditions. You can take control of the quantitative assessment of your health and learn about male and female hormone balance, the stress hormone cortisol, leaky gut, gluten intolerance, or your gut microbiome.
Take a more active role in tracking your health and take 20% off your first order of a mail-in testing opportunity with the discount code PEOPLE. That's uppercase PEOPLE. To learn more, go to Verisana.com. That's Verisana.com. Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. If you'd like to purchase a CD of today's show or any People's Pharmacy episode, you can call 800-732-2334. Today's show is number 1171. That number again, 800-732-2334, or find it online at peoplespharmacy.com. You can also download the free podcast from Apple, Stitcher, or from our web store. We invite you to consider writing a review.
The People's Pharmacy is brought to you in part by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. KAYA Biotics.com.
We're talking today about digestive disorders. When your stomach hurts, it gets your attention. What do you do when you have heartburn or diarrhea? Proton pump inhibitors like Prilosec or Prevacid are very popular, but they have become controversial. When are they appropriate?
Our guest is Dr. Robin Chutkan. She's on the faculty at Georgetown University Hospital and is founder of the Digestive Center for Wellness in Washington, D.C. Dr. Chutkan is a board-certified gastroenterologist and the author of 3 books on digestive health. The first was Gut Bliss, which is also the name of her website. She's also written The Microbiome Solution and The Bloat Cure.
Dr. Chutkan, as we understand it, the colon is lined with mucus that the cells of the colon have secreted to protect themselves. If we don't provide our gut microbiota with enough fiber, do they start to chomp on that mucus?
They do. We actually start to auto-digest ourselves, Terry. It's really fascinating. There's a publication earlier this year in a journal called Cell, and researchers were able to show the impact of a low-fiber diet in the gut. And the most important aspect of that impact is that they raised these special mice without any germs, and then they studied the impact of different diets and also infecting the mice with different strains of bacteria. And the basic result of this study was that the mice who had a high-fiber diet had a mucus layer that was nice and thick. And furthermore, when they infected those mice with bacteria like E. coli that usually cause gut infections, the infection really didn't take hold. The fiber diet, not only did it produce a nice thick mucus layer to protect the lining, but it was also protective against some of these GI infections, which was really incredible. And then when they had mice on the low fiber diet, they saw that the mice were producing enzymes called glycoproteins, that the mice were producing enzymes that were capable of breaking down these glycoproteins that are part of the mucus layer. So it not only does a fiber, again, protect the lining by forming nice thick mucus, but it also provides a lot of protection against infection. And that was something we really weren't aware of.
Dr. Chutkan, we've been talking about the lower digestive tract, primarily the colon, but I'd like to just segue for a moment in this conversation about mucus to the stomach. I was fortunate enough to have a class on physiology with one of the country's foremost gastroenterologists, physiologists, however you want to think of Dr. Davenport at University of Michigan many, many decades ago. And Dr. Davenport spent a lot of his career asking why the stomach doesn't digest itself. I mean, when we think about hydrochloric acid and what a powerful acid that is and how it can basically dissolve away a penny, how is it that it doesn't dissolve away our stomach? And apparently that's all because of mucus. What can we do to protect our mucus, not just in our colon, but also in our stomach? Because we put things in there that aren't necessarily nice to that stomach lining, like alcohol and non-steroidal anti-inflammatory drugs. What should we be doing?
So, Joe, I'm so glad you mentioned the stomach lining, because that is, again, a great example of how the diet can help to reinforce a natural physiologic function that's protective. So just like with the mucus layer in the colon, for the stomach, we need a high fiber diet too, to make sure that we have adequate protection there. And then you mentioned 2 really important things: avoiding alcohol, avoiding nonsteroidal anti-inflammatory drugs, and avoiding other things that most people aren't ingesting on a regular basis, like lye, for example, in household cleaners and so on, things like that can damage the mucus lining. We do see that certain bacteria actually can have a detrimental effect, and I'm talking primarily about Helicobacter pylori, H. pylori. When you have H. pylori infection in the stomach, that can cause some damage to the lining and to the mucus lining too. But for the most part, it really is having a diet that's high in fiber and avoiding some of these things that are toxic to the digestive tract. And alcohol and nonsteroidal anti-inflammatory drugs can affect the GI tract throughout its entirety. So not just the colon or the stomach, but the upper tract, the small intestine, as well as the large intestine.
Well, we hear a lot of confusion and a certain amount of anxiety about that acid in the stomach because we have these proton pump inhibitors, these acid suppressors that are incredibly effective and can help heal an ulcer quite well. But a lot of our listeners say, but wait a minute, weren't we supposed to have acid in our stomach? Isn't it necessary for digestion? And if we suppress acid, what are the consequences? And some people even go so far as to say, when I have heartburn, I take a little apple cider vinegar, and seemingly miraculously and counterintuitively, it helps with my heartburn.
It doesn't work for everyone, Joe.
No, it doesn't. So I'm kind of curious. Can you give us a crash course on acid in the stomach and PPIs versus apple cider vinegar for heartburn?
I'd love to, Joe. So first of all, stomach acid is probably the most important component of digestion. That's digestion 101. You need to have stomach acid to digest food properly. And you don't have stomach acid because you've been taking one of these proton pump inhibitors long term for more than a few weeks at a time. These drugs are incredibly efficient at blocking stomach acid. So when you've been on one of these drugs for even more than a few days, you literally have no stomach acid. And what that means is that you are not absorbing nutrients optimally, as well as certain minerals. So for example, calcium and magnesium are both suboptimally absorbed when you're on a proton pump inhibitor. And this can lead to low magnesium, and it can also lead to issues with increased risk of fracture for the bones, because when you're not absorbing calcium properly, you're now at increased risk for osteoporosis, etc. There can be certain kinds of anemia. So all the fat-soluble vitamins are absorbed upstream in the GI tract, and that's vitamins A, D, E, and K. So when you're blocking stomach acid, you're going to get suboptimal absorption of these. And even perhaps just as importantly, you're going to get overgrowth and imbalance of gut bacteria, because normally, as you go from north to south in the GI tract, from the mouth to the anus, the amount of gut bacteria increases. So the stomach isn't supposed to have a lot of bacteria. And part of what maintains it as a low bacterial environment is stomach acid. But when you block the stomach acid, as these drugs do so efficiently, now you get overgrowth of the wrong types of species. And so there was a study in one of our GI journals a few years ago that showed that being on a long-term proton pump inhibitor is almost like being on a long-term antibiotic in terms of the effects on your microbiota. So these drugs are really problematic. And then, of course, there have been other reports of these drugs, long-term use being linked to things like kidney disease and heart disease, and even some reports of dementia. It's hard to prove cause and effect with some of these other conditions. There are lots of other things that could be contributing. But in terms of interfering with digestion, there's no question that these drugs dramatically interfere with digestion and absorption of nutrients and minerals.
Well, when you talk about an imbalance of the gut microbiota, we have heard that small intestine, which isn't, again, supposed to have a lot of bacteria, it has some, can become overgrown. And there's some thought that that may be associated with irritable bowel syndrome.
There is, and there's actually a term for that, Terry, SIBO. Some people say SIBO. I say SIBO, S-I-B-O, which stands for small intestinal bacterial overgrowth. There's a strong association with long-term use of PPIs and SIBO, and there's a strong association with SIBO as being one of the causes of irritable bowel syndrome. Of course, when you slice up the irritable bowel syndrome pie, you see lots of different things, but SIBO is one of the things that you see. So again, you see really the interconnectedness of all these things. And while pharmaceuticals can be life-saving and life-changing, they can also wreak havoc in the gut, as we've heard today.
Now, Dr. Chutkin, we've talked about antibiotics and how they kill off a lot of the microbes in our digestive tract. If we wanted to reestablish our microbes, we might turn to a fecal microbiota transplant. Can you tell us about that, please? And then tell us, what about super poopers as donors for such a transplant?
Well, Terry, yes, fecal microbiota transplant, or FMT as we affectionately call it, refers to introducing actual feces. So taking a probiotic is just taking live bacteria, but FMT is going one step further, and it's actually going direct to the source and taking the actual stool and introducing it into the gut, either from below right into the colon during a colonoscopy procedure or as a fecal enema, or sometimes above, either through a nasogastric tube that we can put in, or there have been stool pills that people have formulated that you can take. But, that's a rather extreme form of therapy. And many, many people who would benefit from FMT would also benefit from just a significant dietary change. So rather than reintroduce the organisms, you can just feed your existing organisms differently by, again, giving them more fiber. But for certain conditions, and the classic one is a kind of infection called Clostridium difficile, C. difficile infection, where the C. difficile bacteria grows out of control in the colon, and it's treated typically by antibiotics. But a series of studies a few years ago showed that FMT was actually more successful than antibiotics for treating C. diff. And the theory behind that is that when you reintroduce a stool that's full of normal, healthy bacteria, it simply crowds out the C. diff and gets the infection under control. In my world, FMT is really exciting because I see a lot of patients with chronic autoimmune digestive diseases, namely Crohn's disease and ulcerative colitis. And there have been a number of fascinating studies that suggest that FMT could offer treatment and even remission for some of these patients. However, a lot of it is dependent on the stool. It's like any other transplant. If you get a heart transplant or a kidney transplant or a liver transplant, the success of the transplant is only as good as the health of the organ. Well, all stool is not created equal. So if your stool donor for your FMT, for your stool transplant, has been eating fast food every day and doesn't eat any vegetables and drinks a lot and is on a lot of different medication and is taking a lot of antibiotics, you're not going to have a very robust effect. Versus you've got a stool donor who's plant-based and is eating 30 or 40 or even 50 grams of fiber a day, not on any medication, really healthy, even better if they're getting outdoors and getting exposed to more soil microbes because that enhances their own microbiome. So, we were a little bit naive in thinking that it doesn't matter, just get some stool and pop it in there. And new research suggests that stools from these so-called super donors or super poopers have such rich microbial diversity that when we use those samples for a fecal transplant, they have a much more significant impact, particularly on some of these chronic conditions like inflammatory bowel disease, multiple sclerosis, or even some trials now looking at Alzheimer's. And it's because they have high levels of certain bacteria that can really help to restore the microbial diversity that's lost in a lot of these conditions.
Dr. Chutkin, how would we know whether we have a good microbiota, a good diversity, or because of the antibiotic we took for perhaps an abscessed tooth or a skin infection, that we've kind of messed things up and that it hasn't returned to normal? Are there any ways to determine the state of our microbiome?
There are, Joe, but I'm all for empowering the citizen scientist, and there are lots of companies that do microbiome sequencing, but our ability to really interpret this and say, this is good, this is better, this is best, is pretty limited. So it's sort of like how you know you're healthy. One way is you can go to the doctor and get some supporting evidence. Well, you got your lipid panel, it looks pretty good. They checked your blood pressure, your blood sugar looks good. But a probably more important part of knowing whether you're healthy is how you feel. What's your energy level like? What's your mood? Are you stiff? How do you sleep at night? What are your bowel movements like? So these things are really probably more important markers than what the lab tests look like. And one could argue the same is true for the microbiome, because the testing is really in its infancy, and we don't really know yet what the perfect or the ideal microbiome looks like. It's sort of like saying, well, what does a perfect man or woman look like? Are they 5'11" or 6'4"? Do they weigh 150 pounds or 180 pounds? Is their hair brown, black, or blonde? So there's a lot of variation, and there's also a lot of adaptation within the microbiome. So sometimes we see changes and we don't know whether it's cause or effect, or whether it's an adaptation, an adjustment to a certain environmental condition that it's actually helping rather than hindering. So while this testing can be done, it's relatively cheap. You can get your microbiome sequence for under $100 from most of these commercially available companies. The interpretation is still something we're working on. I encourage people to do the testing because that allows us to build large databases and then to be able to look and figure out some of these microbial signatures. A lot of the data we know, for example, about the species changes in something like Crohn's disease, we know because we've tested a lot of people. But we're not yet at the point where we can look at a microbial sequencing sample and we can predict whether that person has disease or not. We're getting there, but we're not quite there yet.
Dr. Chutkan, what should our listeners think about as one of the most important factors for good digestive health?
Terry, you ultimately are what you eat. And remember, you're not just feeding yourself, you're feeding your trillions of microbes that live in and on your body and that are involved in every single bodily function. They're breaking down the food. They're synthesizing vitamins and hormones that we can't make on our own. They're detoxifying compounds. They're helping with they're training our immune system. They're turning genes on and off. So you've got to feed them the right stuff or else they aren't going to be able to perform optimally. And what's the right stuff? I think Michael Pollan said it best in his 7 words: eat food, not too much, mostly plants.
Dr. Robin Chutkan, thank you ever so much for talking with us on the People's Pharmacy today.
Always a pleasure, Terry and Joe.
You've been listening to gastroenterologist Robin Chutkan. That's Chutkan. Dr. Chutkan is founder of the Digestive Center for Wellness in Washington, D.C., and is on faculty at Georgetown University Hospital. Her 3 books are Gut Bliss, The Microbiome Solution, and The Bloat Cure. Her website is gutbliss.com.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is brought to you in part by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
If you would like to purchase a CD of today's show or any other People's Pharmacy episode, you can call 800-732-2334. Today's show is number 1171. That number again, 800-732-2334. You can also find it on our website, peoplespharmacy.com.
When you visit our site, you can share your thoughts about today's show. Have you experienced diverticulitis? What did you do about it? Share your story.
At peoplespharmacy.com, you can sign up for our free online newsletter or subscribe to the free podcast of the show. You need never miss another episode. You can even share it with a friend.
When you sign up for the newsletter, you'll get our free e-guide to favorite home remedies. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please do join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.